everyone, and welcome to the first episode of the Endo Insight, a space where we dive deep into an important, under-discussed topic in women's health: endometriosis. This is a space for endometriosis warriors, people who suspect something's not right within their body, or anyone who's interested in learning more. So what is endometriosis? Endometriosis is an inflammatory, estrogen-dependent condition. It is most associated with pelvic pain, painful periods, and infertility. It is defined as the presence of endometrial glands in ectopic locations. This means tissue is found outside the uterus. Common sites include the ovaries, fallopian tube, bladder, or bowel. This tissue acts similarly to endometrial tissue in the uterus. It thickens, breaks down, and bleeds. However, unlike the endometrial lining, this tissue has no way to exit the body. The result is chronic inflammation, scar tissue, and adhesions. This can cause organs in the pelvis to stick together. Endometriosis affects 1 in 10 people assigned female at birth. That's about 190 million people worldwide, with a peak prevalence between 25 years and 35 years of age. Several risk factors have been identified that may increase a woman's likelihood of developing this condition. Women who began their menstrual cycle at an early age, which is often defined as 11 years and younger, may be at risk. This early onset is associated with a longer exposure to menstrual cycles. Similarly, those with short menstrual cycles, which is fewer than 27 days, or experience heavy, prolonged periods, are also more likely to be affected. Never given birth is also another risk factor, as is late-onset menopause, as both contribute to a longer duration of estrogen exposure. A low body mass index may also be associated with an increased risk of endometriosis, although the underlying mechanism behind this relationship are not fully understood. Importantly, genetics play a significant role in endometriosis. Research has shown that having a first-degree relative with endometriosis increases a woman's risk by approximately 7 to 10-fold. There are 3 clinically recognized types of endometriosis, each varying in severity. The most common form is superficial peritoneal, which accounts for 80% of endometriosis. This is where endometrial-like tissue grows on the surface of the pelvic lining called the peritoneum. Next is cystic ovarian endometriosis, also known as chocolate cysts. These are dark blood-filled cysts on the ovaries. This type is called chocolate cysts because the fluid inside them is dark due to old blood. And thirdly, deep infiltrating endometriosis. Tissue grows deep into pelvic organs. It is characterized by lesions penetrating more than 5 mm below the peritoneum. This can lead to significant pain and often requiring surgical management. Symptoms can vary from person to person, but the most common include severe menstrual cramps, chronic pelvic pain, pain during sex, pain during urination or bowel movements, fatigue, and infertility. Some individuals with endometriosis experience debilitating pain that prevents them from going to school or work. As well as this, there is also an emotional toll. Some individuals with endometriosis live with severe anxiety, depression, and isolation, and not just from the pain, but from being dismissed repeatedly. Let's talk about diagnosis. On average, it takes 6.7 years from the onset of symptoms to receive a formal diagnosis of endometriosis. Why? Well, there are several factors that contribute to this delay. Part of the reason is that some symptoms mimic other conditions like irritable bowel syndrome, fibroids, and adenomyosis. Because of this, patients are often misdiagnosed and told their pain is normal. Also, some doctors often dismiss patients' pain, which in turn delays them from receiving appropriate treatment. The path to diagnosis typically begins with a consultation with a general practitioner, who will take a detailed history of the patient's symptoms. They may ask about menstrual patterns, bowel movements, and whether any family members have endometriosis. A physical examination may be carried out to check for signs of tenderness or abnormalities in the abdomen or pelvic region. While a blood test may be taken, it is not used to directly diagnose endometriosis, but rather help rule out other potential causes of symptoms. If the doctor suspects endometriosis, based on the patient's symptoms and history, the doctor will typically refer them to a gynecologist. The next stage would be the use of imaging tests to examine the pelvic organs more closely. This can be an ultrasound scan, particularly a transvaginal ultrasound. A probe is inserted into the vagina to obtain a clear image of the ovaries. This will be able to show if there are any ovarian cysts. Some patients may undergo an MRI scan, especially if deep infiltrating endometriosis is suspected. However, the gold standard for diagnosis remains laparoscopy. This is an invasive surgical procedure where a small camera is inserted into a small incision in the abdomen. This allows the surgeon to directly visualize the pelvic organs and look for the presence of endometrial lesions. During a laparoscopy, the surgeon may take a biopsy, which is a small sample of tissue, for it to be sent to the laboratory for histological confirmation. As it is a surgical procedure, it is not offered lightly, and patients may wait years before getting one. Ultimately, the current diagnostic pathway for endometriosis reflects a broader issue within healthcare: the failure to take menstrual and pelvic pain seriously, and a deep need for more education and earlier intervention. Now let's shift to a critically important aspect of patient care: the racial and ethnic disparities that exist in the diagnosis and treatment of endometriosis. Historically, gynecology has been shaped by deeply embedded racial biases. One of the most notorious figures in this history is Dr. J. Marion Sims, often referred to as the father of modern gynecology. In the 19th century, Sims performed multiple invasive procedures, including the invention of the vaginal speculum on enslaved black women without anesthesia. These women could not give consent and were subjected to repeated experimentation based on the racist and unfounded belief that black individuals feel less pain. Unfortunately, this harmful belief persists in modern medical care. Studies have consistently shown that black women are less likely to have their pain believed or taken seriously by healthcare professionals. In the context of endometriosis, a condition that already takes an average of nearly 7 years to diagnose, this adds an additional layer of inequity. Many patients from ethnic minority backgrounds are misdiagnosed, dismissed, or denied timely referrals despite presenting with typical symptoms. In the United States, approximately 72% of patients formally diagnosed with endometriosis are white, while only 5% are black. This stark imbalance cannot be explained by biological differences. Rather, it reflects systemic issues, including clinician bias and disparities in who gets referred for specialist care. A similar pattern is seen in the United Kingdom, where women from ethnic minority backgrounds frequently report feeling dismissed or overlooked when presenting with pain. Many report being told their symptoms are normal or exaggerated. The consequences of these disparities are serious. Delayed or misdiagnosis of endometriosis can lead to disease progression, chronic pain, infertility, organ damage, and significant psychological distress. These disparities highlight the urgent need for change within the healthcare system, both in promoting more inclusive research and ensuring healthcare professionals listen and understand patient experiences. With this in mind, let's now explore the current treatment options available for managing endometriosis. Currently, there is no definitive cure for this. However, treatment primarily focuses on managing symptoms to improve a person's quality of life. These treatments typically involve a combination of medication and, in some cases, surgical intervention. Non-steroidal anti-inflammatory drugs, or NSAIDs, such as ibuprofen and naproxen, are often prescribed to alleviate the cramping and inflammation associated with endometriosis. These medications are effective at reducing day-to-day pain. Beyond pain relief, hormonal therapy is a cornerstone of medical management. The aim of hormonal treatments is to suppress the normal menstrual cycle, which in turn slows or stops the growth of endometrial tissue. These therapies come in several forms, including the combined oral contraceptive pill, progestin-only pills, and intrauterine devices, IUD. The IUD is a small T-shaped device that is inserted into the uterus and slowly releases progestin over time. While hormonal treatments can be effective in controlling symptoms, they may come with side effects. These can include weight gain, mood changes, acne, and in rare cases, an increased risk of blood clots in the legs or lungs. For those with more severe or persistent symptoms, more advanced hormonal options are available, such as gonadotropin-releasing hormone, GnRH analogues. These medications work by inducing a temporary menopausal state through the suppression of ovarian hormone production. By reducing estrogen levels, they help shrink endometrial lesions and relieve symptoms. However, due to potential side effects such as bone thinning, GnRH analogues are generally only used for short-term treatment. In cases where medication is insufficient, surgical intervention may be considered. Laparoscopic surgery is a minimally invasive procedure used to locate and remove or destroy endometrial tissue. This can significantly reduce pain and may improve fertility outcomes in some patients. That said, recurrence of symptoms is possible, and like any surgery, there are risks involved, including infection, damage to nearby organs such as bladder or bowel, and the potential for blood clots. It's also important to recognize that endometriosis doesn't always require active treatment. In some cases, symptoms may improve over time without medical intervention. However, for others, untreated endometriosis can worsen and significantly impact quality of life. Therefore, deciding whether to have treatment is often a personal decision that involves weighing the risks and benefits in consultation with a healthcare provider. Ultimately, treatment for endometriosis should be highly individualized, considering the severity of symptoms, the person's reproductive goals, and their overall health and preferences. One of the most emotionally and physically challenging complications of endometriosis is infertility. For a pregnancy to occur naturally, an egg must be released from the ovary, travel through the fallopian tube to be fertilized by sperm and implant into the lining of the uterus. Endometriosis can interfere with this process. Scar tissue and adhesions from the disease may block the fallopian tubes, preventing the egg and sperm from meeting. In some cases, the inflammation can damage the egg and sperm directly or create a hostile environment that prevents implantation. It is estimated that 30 to 50% of patients with endometriosis experience infertility. However, the extent of this impact often depends on the type, location, and severity of the disease. For example, deep infiltrating endometriosis is more associated with fertility issues, as the spontaneous fertility rate ranges from 2 to 10%. But it is important to mention not everyone with endometriosis will face infertility, and many go on to conceive naturally. For those who do struggle, assisted reproductive technologies such as IVF may offer promising outcomes. Moving on, let's talk about the possible causes of endometriosis. While the exact cause remains unknown, several well-established scientific theories have been proposed to explain how endometriosis develops. One of the most widely accepted is Sampson's theory of retrograde menstruation, first proposed by Dr. John Sampson in 1927. This theory suggests that during menstruation, some of the endometrial tissue flows backward through the fallopian tubes into the peritoneal cavity. These displaced endometrial cells implant onto peritoneal surfaces and begin to grow, leading to endometriotic lesions. Although retrograde menstruation occurs in most people who menstruate, it is thought that certain individuals may have reduced ability to clear these cells due to immune dysfunction or other factors. Another theory is coelomic metaplasia. This theory was first proposed in 1924 by Robert Meyer. According to this theory, endometriosis may arise when cells that align the peritoneum undergo a process called metaplasia. This means that these cells transform into endometrial-like cells. But what causes this transformation? It can be hormonal signals or inflammatory mediators like cytokines that trigger this change. What makes this theory especially valuable is that it helps explain some cases that can't easily be accounted for by retrograde menstruation alone. For instance, the rare but documented occurrences of endometriosis in men. In addition to these theories, there is increasing evidence supporting genetic predisposition to endometriosis, as mentioned earlier. Importantly, endometriosis is now widely considered a multifactorial and systemic condition, rather than purely a gynecological disorder. While it primarily involves the reproductive organs, its impact extends far beyond the uterus and the ovaries. The condition arises from a complex interplay of genetic, hormonal, immunological, and environmental factors. And understanding that complexity is key to improving diagnosis, treatment, and support. Thank you for tuning in to this episode. We've covered a lot today, from symptoms to treatment options and possible causes of endometriosis. If you found this helpful, consider sharing it with someone who might benefit from it. Until next time, bye everyone.